All right, we're going to get started with the last panel. Certainly last but not least, one of the things that we learned in the first 2 years of MedtechVision is one of the most intriguing and exciting topics in the main sessions, during the wine reception, and all the breaks, and even in some cases in Q&A during the dinner keynote, is about emerging markets. And I think that the reasons are obvious, but what we've tried to do each year is frame an emerging markets panel in the context of the theme that we're exploring. And of course, this year that's about value. And for people who do work outside the U.S. in commercialization of medtech products, I think you have a lot to teach us that have been focused, those of us who've been focused only in the U.S., about how you locally define value in a given geography or a given market, and how the stakeholders on the ground there must be the ones that help you define that. It's very difficult, increasingly difficult to do from stateside, and certainly from here in the Silicon Valley bubble for those of us who are here. And so Mika Nishimura is going to come here and lead us in this panel number 5 to explore this idea. She's the Vice President of Commercial Development at Oxygen, and I'll let you take it from here, Mika.
Okay, I know we're standing between you and wine reception, so we've got a work cut out for us. So, as Deb introduced me, I'm Mika Nishimura. I'm Vice President of Commercial Development at Oxygen. I'm also a part-time operational advisor for Gilda Healthcare, which is a Dutch-based VC firm focusing on investments in commercial stage companies. So I wear 2 different hats here. I've been in medtech space for about 20 years now, and mostly in sales and marketing, and most of that actually international markets. So I first started going into the so-called emerging markets in the 1990s when my then employer Guidant asked me to help build a business over there. And so a team of us kind of thought, okay, you know, rest of the world, as that was called back then, was somewhat derogatory. And so we wanted to come up with a more catchy acronym. So we had a brainstorming session. And one of the team members actually suggested safe sex. South America, Far East, and select export markets. But kind of then, like, we thought about it, okay, how do we get up in front of the Guidant Management Committee every 3 months and talk about the performance of safe sex? So we ditched that name and went with a more plain vanilla one. And I know that in many of the companies here that it's either called, emerging markets or intercontinental or whatnot. But much has really changed from those days, when we first started going to emerging markets. So I'm really excited about this panel. We have a women who are very attuned to, immersed in leading their company's efforts in emerging markets at various stages. So in a little while, I'll ask them to introduce themselves. But the format of this panel is going to be, I'll just kind of quickly go through some introductory slides just to introduce some themes and set the stage for what our panelists will talk about. But I do want to keep this really interactive because it is at the end of the day, so we'll leave plenty of time for Q&A. So without further ado, I'm going to ask Zoya to start off with introduction.
Hi, I'm Zoya Brar. I'm the co-founder and director for Core Diagnostics. I usually, whenever I'm told to introduce myself, I start introducing my company. I'm that engaged with it. So this is a fairly new company. We started about 1 year ago. I was working at Google before this. Decided that, if I have to ever set up my own company, might as well do it early before, marriage and kids and all of that happens. So quit and looked at, what are my options. So went from looking at event management to seaports in India to diagnostics. And finally, kind of closed in on diagnostics. We've managed to get funding from a US Silicon Valley venture capital firm called Artiman Ventures. Maybe you guys have heard of it. And we are doing lots of interesting work, both in India and the US. So we'll cover it during my short stint after this.
I'm Krista Donaldson, and I'm the CEO of a nonprofit medical device company called DREV, and DREV is short for Design Revolution. And we focus on improving health and income of people who live on less than $4 a day. And our primary markets are in India, but we have 2 products I'm going to talk a little bit about today, and I brought some gadgets, as we're now calling them, that are now starting to scale globally, which is really exciting for us.
My name is Wendy Shao. I am the managing director for a mid-cap life science tools company called Techni. Where 30% of the revenue that we came from clinical diagnostic labs in hospitals, and another 70 from the pharmaceutical clinical trial as well as academia. I was back in China about 7 years ago. My boss sent me there. He called it the wild, wild west for me to figure out what to do in China. And I built up a fully integrated business right now in R&D, manufacturing, as well as in sales and marketing. We've been in China for 7 years at the average growth of 30 to 35% year over year. I'm looking forward to share some of the experience that we have in the mid-tier market segment. Traditionally, our business has always been focusing on the premium market. And in China, we look at things very differently and build the company as a startup company over there. So I'm looking forward to share some of my experience over there with you.
And I'm Bonnie Hanky. I'm a senior director for healthcare economics, policy, and reimbursement for the vascular division of Medtronic out of Santa Rosa, California. I'm responsible globally for the renal denervation technology, which is a technology that's approved in many other countries, but not yet in the United States. So we're facing several challenges in Europe, Asia Pacific, as well as in Latin America and many other emerging markets. Today I'm going to talk a little bit about some of our experience in Brazil and share some of our approaches that have been some successful, some not so successful.
All right, great, thank you. Okay. Oops. All right, I'm having a little technical difficulties. All right, let me just skip through some of these slides. So why interest in emerging markets? When traditionally, if you look at medtech device companies across the globe, you would say, all right, it's dominated by U.S. And then Western Europe and then Japan. So emerging markets do remain, a relatively smaller slice of the pie, but it is growing much faster. So for a lot of the companies that already have some sizable presence in the other countries, this really presents growth opportunities because, well, China alone is expected to reach 30 billion in size within the next 5 years or so. And India is forecasted to be $11 billion and double-digit, well over double-digit growth rate. So, and those are really driven by a lot of things that you would suspect it to be: shift in demographics, rising income, more access and coverage of health insurance, access to care, and also growing demand among the patients for better medical care. So those are the driving factors. So Emergo Group, which is a consulting company that I'm sure many of you are familiar with, when they surveyed 2,600 professionals in our industry just a year ago and asked them the question about which markets offer the best growth potential over the next 5 years, you see the BRIC countries being really among the top 5 list. But so there is a large untapped market, which is great. There's high growth, fantastic. The board is putting a lot of pressure on the management team to say, where is your China strategy, or what are you doing in India? Brazil, is a rising star. Tell us about your plans over there. But there are certain things that you do need to consider, that you can't just take the business model that has worked and served you well in the US and Western Europe and Japan and just bring it over there and lop it over the fence and say that, okay, good luck with that. So the challenges that exist in emerging markets, and you can't even lump emerging markets together. You have to think about China differently from India, from Brazil, et cetera. Is really, again, the emerging nature of the medical care and infrastructure. It's going to be different, so how do you add value there? when you think about value to your shareholders, you do have to be mindful of the fact that going into emerging markets requires going in with your eyes wide open, that it does often require lengthy regulatory process, reimbursement process. Things are uncertain. It takes a long time. It may mean that you have multiple generations of products that you end up marketing in far-flung places. So are you prepared to deal with that? You can't just export the same product and hope that you really penetrate those markets. So you may have to think differently about how do I bring products that are best suited to meet the local market conditions, patient demand, physicians' demands. Your business model may have to change. You may be direct in most of the markets you currently operate, but does that really work in many of these emerging markets? What's the channel management? How's your supply and logistics infrastructure looking like? What's your investment time horizon? And finally, many companies have been bitten by compliance issues. Well-known pharmaceutical companies, Guidant, et cetera, have been heavily penalized by lack of compliance in the past. So that's another risk that you run. So a rather simplistic view of what does value mean, you can kind of think about it in, okay, are you selling a full-featured, high-end premium product at that sort of price, like a Mercedes, versus do you export a Yugo with all the stripped-down versions, or is it a Honda Civic, somewhere in between? But that's a fairly simplistic view. We'll talk about really value in the larger context during this panel discussion. And as Wendy alluded to, okay, how do you really define the different market segments even within emerging markets? So taking China, for example, are you tapping just into the premium segment, or are you now moving into potentially much larger core segment, and what does that really mean in terms of your business model, operations, products, et cetera? So the larger context of value, is not so much just about price, product features, but again, what solutions, what value are you bringing to your partners in each of these local markets? Are you meeting the needs and the realities of some of the local conditions? And we'll have some of our panelists talk about that in terms of their solutions meeting those local conditions. What training are you supplying for adoption by the clinical community? A lot of the patients in these markets, don't have the same access to knowledge about what are the alternatives, what are the options. Are you supplying those solutions to them? And what service and support are you willing to provide? So, and this has been really an evolutionary process. So the first phase of going into emerging markets for many of us, was literally going in there with the same product that we had and, just hoping that you can sell some of that or even get rid of the old generation product, that were about to expire. So that worked well, perhaps about 20 years ago. But then quickly there was local competition, people that just jumped into this market that was created by the Western companies and, offered either just good enough products at much cheaper price or came up with a more innovative solution that really met the local needs. So those local companies quickly gained share, for example, in the cardiology segment in China. And then there's been the third phase where okay, multinationals did catch on. They adjusted their business models. They brought in a lot of investments into training and patient education, et cetera, so they are regaining share, for example. But the final frontier is really what I'm really excited to hear from some of our panelists, and that is actually the reverse export of value from emerging markets back to some of the other countries that would have looked upon these products as coming from these markets as perhaps untrustworthy. So an example of this is really GE Lullaby Warmer, where they have actually developed this specifically originally for India, but are now exporting it back to Western countries. And we have a couple of examples from our panelists that will talk about this. So without further ado, I'm going to turn it over first to Bonnie so that she can talk about some of the challenges in terms of, again, how do you emphasize value when you bring innovative, game-changing technology like renal innovation into emerging markets like Brazil. So.
Thank you. So first of all, I'm going to start out by just giving you some brief details on the healthcare system in Brazil, and then talk a little bit about our approach to achieving reimbursement in the country. Brazil has a current population of about 195 million. As Mika mentioned, this is a country that the economy is growing, the population is growing, and the poverty level is decreasing. Currently, about 75% of the population is covered under the public healthcare system. This is tax funded, and I would add that it's significantly underfunded. So the payments are low and there are restrictions. The other 25% has private insurance, which most of them pay for out of their own pocket, or employer coverage is in some instances. But the interesting thing is only about 47% of the total expenditures for the country are funded by the public system, which means that approximately the remaining 53% are covered by that 25% in the private system. And of that, almost 22% to 23% is actually out-of-pocket expense by those people in the country who have the funds to actually cover their own expenses. So it's a challenging system to be in. The country has tried to find different ways to add funding, things like that, but the reality is the private sector has grown significantly because of the decrease in poverty, and the increase in the middle class population, and their desire for health care insurance. They're looking for access to health care. They're more aware of the benefits of receiving adequate health care. So there's a lot of motivation amongst the people in Brazil to actually improve this. There are health technology assessments that occur in both the public system as well as the private system. They are coordinated to some degree, and to a certain extent, the technology assessment that's done for the public sector does influence the private. However, that private system still does have the autonomy to add certain devices, technology, procedures to their list of covered procedures. One of the things that we're noticing as a medical device company is a significant increase in our interactions with that private sector. So while only about 25% of the population is covered under that sector, we're receiving significant requests for various different things, such as they'd like to have national pricing agreements. And typically those national pricing agreements would call for pretty significant reductions in the product pricing. They're also looking for technical education on the product, so they want to know how it works, under what circumstances it should be used, things like that. They're also looking for utilization criteria, and for this they're really looking at who is the right patient who should receive this procedure, and how do we make sure that we limit this to those patients. And then the last thing that they're asking for is a local economic evaluation. So we've talked a lot today about the need for economic evaluation, and the one thing that I would say is, first and foremost, any new technology should have that economic evidence to support it. You're always going to need safety. You're always going to need efficacy evidence. The economic piece is one of those aspects that if you haven't started to build it, now is the time to start to build it. And I would also say that to a large part, you need to have country-specific economic evaluations. So when you're building your economic model from the get-go, make sure you have a model that can be adapted in each country. Because what we're seeing is no longer is the model that was created in the US or the UK or wherever it may be, that's not adequate. Each country wants to see and have their various attributes added to that model so they know how it's going to actually result in their particular population. Now, I would say for the most part, if a technology is cost effective in one country, it's going to be cost effective in the next country. But for those countries with very low expenditures, the costs of those procedures are much lower than they are, say, in the United States. So the cost effectiveness will change to some degree, and that's something that they want to know when they're making their decisions as to how to spend their money. The other thing we're noticing, and I think you'll hear that some of these trends that we're seeing in Brazil are very similar across the rest of the world. It's sometimes how we deal with them that are different. So, as I mentioned earlier, the demand for healthcare is increasing, and this is largely due to the aging population, the increased desire for access to healthcare, and the awareness of the healthcare options that exist. Their current payment models are failing, so they're looking for new options such as increased demand for negotiations on pricing. They're also looking at different options such as pay for performance and other models that they're seeing the rest of the world use. Many of their providers, just like in other countries, are moving into more of a network situation versus individual practice. So those providers are actually gaining in terms of their negotiation ability. There's a lot of technical development going on in Brazil, and then we're also seeing a lot of changes in the industry sector. So we're seeing consolidation, integration, and the influx of foreign capital. Right now, there's about 992 different insurance plans in the private sector, and we're seeing some of that collapse. So as those collapse, I think it may become a little bit easier to work with that sector, but that's a pretty large number of different plans to work with. As I mentioned, we're focusing our attentions on both sectors, but to a large degree, the focus has shifted almost to a larger degree to that private sector, just because that's the sector that's growing, and it's likely to be the sector where we're more likely to actually be able to see the technology adopted, given the difference in the systems. But at the same time, we try to always understand all of our stakeholder needs. And when we map out all of the stakeholder needs, it's very evident that oftentimes the needs are at cross purposes of each other, and that's something that as a company you need to weigh. The other thing is you're not always going to be able to meet the needs of every stakeholder in every country. And as we look at the markets that we're going into, we always try to address what can we answer for these countries and what can we not answer, and then what is the impact on our ability to grow in that country. As I also mentioned, some of the must-haves, safety and efficacy first and foremost. Once you've achieved that, the value and benefit are extremely beneficial, and then the local economic evaluation. And one of the things that we've tried to do as we've adapted, I'm using the renal denervation model, as we've adapted that in the various countries, we always want to make sure that we can get that published in the local country. And typically we do that through various health economic conferences such as ISPOR or HTAI, and get it published in the journals. And then as we have more and more adaptations done, the goal would be to ultimately be able to publish something that's a consolidation of all of the various economic evaluations to show the consistency from one country to the next and the adaptability of the model, so that the decision makers understand what the various inputs are, how the model was created, and they can replicate it. For many of these countries, that's first and foremost. They need to be able to take the model, get into the nitty-gritty of it, and replicate it to make sure that they're never going to trust industry for providing them something that says something is wildly cost-effective. They want to see and feel it and manipulate the inputs for themselves.
Great. Thank you, Bonnie.
Yep.
So now I'm going to shift a little bit, but sort of along the same sort of themes is, what is your value proposition to the different stakeholders and different segments of the market? So, Wendy, I know that, you have had experience in China with that segmentation analysis, so I'd like you to share some of your thoughts.
Okay. Wonderful. Thank you. Actually, about 7 years ago, when I returned to China, our strategy is only target the premium market in China. Why all of a sudden the mid-tier market becomes so interesting to us? Because there are a couple of things happened. There's a huge demographic change with the aging population. Currently, it's about 120 million for people with about 55 years or older. But the expectation is within 10 years or so, the number is going to double. It's close to 300 million people. The aging population creates a huge social and economic issue for the government. And second point is with the diet change as well as the pollution. So the disease incidence increasing significantly. As Bonnie mentioned, with the more sizable affluent population, mid-tier, mid-class population, there's more disposable income people can use and more conscious awareness about their health in the future. So this creates an enormous interesting market to us. In addition, the government health care reform policies increasing the coverage of the really tertiary, not only in the tertiary hospitals, but also the secondary hospital and the grassroots healthcare clinics create a significant amount of opportunities as well. Just between 2009 and 2011, the government has invested 160 billion to upgrade the hospital's infrastructure, and also there's a 12th five-year plan. I'm sure most of you perhaps heard about it. It's a huge effort made by government to invest in local companies to create innovative technologies to make healthcare more affordable to the general population. All these created huge interest to the mid-tier market, which accounts for 25 to 30% of the total healthcare market. What we think, why we're interested in this mid-tier market is not only a defensive play, but also an interesting market opportunity where we could take some of our technology existing in the U.S. home market and extend the life cycle in those emerging markets. And I lay out the hospital infrastructure on the slides here. The tertiary hospital currently capture most of the patient flow, but it only has around 3,000 to 5,000 or so tertiary hospital. There, the doctors are very well trained. You have very skilled workers, and the reimbursement policy is very well set. However, if you go to the secondary hospitals, the regional healthcare center, you will face the doctors, the certification, doctors with certification is less qualified, and there are a lot of skill dependent, procedures that needs to be relooked at, and the reimbursement policy is not as at a high level as some of the tertiary hospital, teaching hospitals. And if you go down to the grassroots, town ownership and rural clinics, it's even more of an issue. So because of the different staffing, management, as well as the reimbursement policies, so we really need to look at the mid-tier market strategy from the regional perspective, develop products really based on the local market needs, and that's the strategy that we take to develop really the products to gear toward the mid-tier market. Some of the factors that we take into consideration, first of all, is the affordability. When you enter into the mid-tier market, you face a whole lot more local competition. So as I mentioned in my previous slides, the government has invested a lot into the local companies to create innovative technologies. So we face a lot of the local competitions on cost competition, as well as some of the government favorable policies. How do we addressing that issue is we aggressively partner with local companies. That's one of the strategies that we take on many products, many of the interesting product or disease areas that we look at. Secondly, there's an accessibility issue because when you go into more the second tier, third tier markets that are very rural or remote, you'll run into distribution channel issues, whether you have access to distributors who have very strong local relationships is a key consideration that we need to take into facts and really early on make sure that we have a very good distribution access. And there we have a local team to access each of the product or product portfolios. How do we get access to these third tier, second tier, third tier market? and also the accessibility, because as I mentioned, the local companies, when it comes to reimbursement policies or government relationships, they may have an advantage to work with the government, or they get regional government support in some of these approval process. So there we also want to work with them closely to make sure that our product can get access to these connections or relationships. The last but not the least is because we have always been played in the premium pricing market, and a lot of my time is spent internally to get internal alignment or support for mid-tier market strategy, because one of the key thing is how do we make sure our mid-tier market strategy is not cannibalizing some of these local products that we develop, and make sure that they're not back export into the international market to threaten some of existing product portfolio. That's something that we work closely with each of our stakeholders inside the company to make sure that they're not cannibalizing our existing market. So I have a strategy how we address those is on the more innovative, differentiated product. We play in the premium market segment, the products that we have a lot of patent and internal know-hows. We segment that from the mid-tier market using a premium brand strategy. But into the mid-tier segment, we build multi-brand strategy, a fighter brand that only target the local market. And also we do a lot of market segmentation and distribution channel management to make sure that we use different distribution channels to access those markets. And we partnership very aggressive locally to make sure that we take advantage of the relationship the local companies has already built and the pricing advantages or cost advantages that they have through government investment. So those are the key strategies.
All right.
We can get up.
Take over?
Yeah. So hi over here. I was sitting over here and I couldn't see anybody, and I kept turning to my friend and neighbor Pam and saying, "Who's talking?" So hi over here. Okay, so DREV, I already mentioned, we're a nonprofit. We focus on health and income, and I'm just going to talk generally a little bit about what we are and our two products, and then we can get into nitty-gritties of countries and specifics because we've been doing this meta-analysis globally in terms of how we scale, but we can talk about that in a bit. Our mission is to empower poor people to improve their own lives. So as compared to a traditional nonprofit in the medical device space, we don't believe in donations. We really believe in very affordable, high-quality products that people can choose to buy and use and hopefully have impact. 3 things to know about us. One is that we design world-class products. So in many of the countries we operate, we call them emerging markets. I had mentioned that we focus on people who earn less than $4 a day. So while many of you are thinking about, well, where can we maximize profits and expand our markets, we're really looking at the markets that most people are not interested in. We're looking for capacity to pay, but we're also looking where the social need is really high. But that said, traditionally in this space, it's been pretty low quality products. We believe that products should be world-class, meaning if it's a neonatal product, it meets American Academy of Pediatric standards. It meets regulatory requirements, but we'll get into that later. This is a picture of me talking with some prototypes to some doctors in East Delhi. And Zoya and I were exchanging some notes earlier about our work. Another thing I think when people think about emerging markets, I know you're savvier about that because you work in this space, but when I talk to people, they usually think of the picture on the left, that this is what markets look like in emerging markets. A little bit of replication there. Anyhow, but on the right, you see a medical device fair in Delhi, and this is from a few years ago, and actually that's one of our products and one of our engineers talking to a partner organization. We take a market-driven, meaning, like I mentioned, that our products need to be affordable, that they need to be purchased, they need to go through whatever the local markets are. And the reason is because we believe that the product should be economically sustainable. If someone chooses to buy your product, they're seeing value in it. And that means ideally that it'll start to scale on its own without any further donor intervention. One thing I'll add is that we feel very strongly about this because it holds us as an industry and as designers accountable to our users. And I think when we talk about emerging markets, we often have this tendency to not treat them like customers that are paying higher costs in the West. And we feel very strongly that if I'm designing something, regardless of who's using it, I would want to use it with my children. And I think if you look at the history of a lot of kind of lower quality stuff, none of us would want to use it with our families. The third thing is that we're user-centric. We talk a little bit about things that have been designed in the West and transferring them over. We use entirely the opposite model. We start with our users in our target countries, and then we design the product. And the picture you see here is my colleague Vin talking to an amputee named Sandra, and what I have up here are knees, which I'll show a little bit more in a minute. So as compared to making money, our currency is impact. And so we're looking to maximize impact, and that's how we select how we scale and how we do our business models. So the first product I'm going to talk about is Brilliance. And Brilliance is a phototherapy device. And I think one of the great things about having all these women in the room, how many of you have children? Okay, great. How many of you had children who needed to be treated for jaundice? Okay, so statistically, we're about right on. About 12% of all babies need to be treated for jaundice. It's much higher in developing countries, well, 17%, and that's because of things like there's more preterm births. And here you just get put under the phototherapy, the blue lights, but in developing countries, that doesn't happen properly. And so the unmet need for phototherapy is about 7 million babies per year, and it's probably much higher, but it's hard to get data on. If you don't treat jaundice, if your doctors didn't tell you this, the baby can have brain damage or death. And it's pretty hard to track, and if you think about many developing countries, moms are giving birth at home, there's no screening, which is what what she's doing is very important in a lot of the markets. And so by the time the baby comes in to get any kind of screening, the brain damage can already have started. So our mission with Brilliance and our phototherapy work is to end brain damage and death. As I mentioned, it's just blue light. Shines through the skin, breaks down the bilirubin, the baby pees it out. Very simple solution. We don't think about it here in the West. But this is the reality. And when we started this project, actually, we were very focused on rural clinics, which in India, which is our primary market, community health clinics, primary health clinics, where there may be one doctor or a few more. But this is actually what we saw in a NICU in the major public pediatric hospital in Bangalore. And what you're looking at is two babies sharing a device. They're healthy other than jaundice. They're low weight. But you see 6 bulbs on the bottom. 4 of them are burned out. And this is a supply chain issue in many ways. The bulbs are expensive. In Kampala, they can be as much as $200 a bulb. Kampala is Uganda. You need to replace these about every 6 months. So we actually redirected the project now to focus from these more rural clinics to NICUs in urban areas. And so we designed Brilliance, which is about 22,000 rupees, and so you're not allowed to answer. Who knows what that is in dollars? And it doesn't have to be at the current horrible rupee rate.
No, nobody knows. Even I don't know anymore.
It's about $400. And to give you a sense of context, the devices that you have here in the US are about $3,000 or more. Some of them are starting to come down. But by the time they get to sub-Saharan Africa, where we also work, they're about $7,000 or $8,000. And so these are markets that have even less capacity to pay. You'll note that we use LEDs. We also don't use fans. We're really trying to get the cost down as low as possible. Minimize maintenance. Maintenance is a huge issue in many of the hospitals we work in. I also wanted to mention the partnership that brought this product to market. We're based here in San Francisco. We're a team of 9. We'll clear $1 million in revenue this year. So we're very small. We're not going to do manufacturing, distribution, all the sorts of things that really need to make this work. So what you're looking at is our partner, Phoenix Medical Systems in Chennai, India. They're the biggest maker of neonatal equipment in India. We did something unique. They're a for-profit, we're a nonprofit. We license it to them, and we cap the retail price based on the bill of materials. We didn't want our partner to turn around and say, well, most of the devices are $3,000. We're going to make it $2,900. So that's how we got to about a $400 retail. The other thing we did is that we knew the greatest social need was at public hospitals. So we said to them, if you sell, particularly through tenders, to public hospitals, you can keep most of the royalties that you would otherwise pay us. And this is how we tried to align goals. We talked a little bit about aligning goals between your partners. This is where our units have gone as of a few months ago. The Brilliance launched end of last year. And what was kind of cool is we knew some of these devices were going out, but some of them made to the Philippines. They're starting to go into Africa with no marketing on our part. It's where Phoenix had good relationships with partners, but also they saw good value. They saw a product that met American Academy of Pediatrics standards. It was usable. It met all of the regulatory requirements, and it was very affordable. So because we're a nonprofit, I'm going to talk about impact on one slide. This is with the first 172 units reporting. Number of babies treated, it's actually all a bit higher right now. We also look at the number of babies treated who otherwise would not have been treated. So one of the things you want to do as a nonprofit is show that your intervention is actually having an impact. We know that some of the hospitals that our devices go already had effective care. And just looking at the numbers of deaths and disabilities already averted. And really quickly, I'm going to do our other product, which is called the Remotion Knee. It started as a Stanford project. The Jaipur Foot Organization, the largest fitter of prosthetics in the world, came to a Stanford mechanical engineering class and said, we'd like a higher performance knee than this. I don't know if you can see this. It's a single axis knee. It's essentially like a door hinge. I'm going to pass it around. And what the students designed was this. And what you're looking at is a polycentric knee, so a mechanism that's been around since the late 60s. But they did it in plastic, and they were really focused on high performance but affordability. Actually, before I pass around, does anyone know what users might complain about with this? Yeah, you click. And actually, so when I show you the V2, you'll notice something else. One other thing I'll just point out before I pass it around, besides that people don't want to click when they walk, is that when you're sitting, there's actually, there's a drop off here in your pants or your skirt. And we got feedback that they wanted to blend in with their more able-bodied counterparts. So feel free to click away as you pass it around. So the next iteration, the V2, which you're looking at now since we're focused on value, notice anything different? You still click a little bit, but you'll notice that there's a sound dampener in here, noise dampener in here. And so really trying to minimize that noise, and also we streamlined the curvature, trying to be more sensitive to blending in. The other thing you'll notice is that we changed the attachment mechanism from what the Jaipur Foot Clinic was using, which was not ideal in terms of durability, to a more universal adapter. And right now, we are in field testing for our V3, the Remotion Knee. And unfortunately, they all left for Guatemala this morning, but I have a 3D print, and I'm happy to pass around. It's missing the side linkages. But the only thing that's really different from the V2 is, for those of you who have engineering backgrounds, the first two versions were CNC'd, so not particularly cheap, and this one is injection molded. So really trying to bring the cost down so that at retail, it's about $80. And I heard a sigh, which is always nice to hear. The comparable prosthetic knee is about $1,400 made out of metal. The other thing I would add is that we're very aware of our user context. The populations we serve squat more, they kneel more, they sit cross-legged. It's a very different use scenario than typically what we see here in the West. There aren't even sidewalks. There aren't even stairs. There's a lot more dust. And so the designs that we do have to really stand up in these environments and really serve our customers well. So I'm going to end on a video. Kelly really inspired me this morning as the patient, and we have a new video. It's a sneak preview for you all. We're going to release it next month. It's a young boy named Dinesh. And we had a volunteer filmmaker who went to India and met Dinesh, and so you're going to see a 1.5-minute clip of him just getting fit with the knee. So he's in the process of getting fit.
मेरा नाम दिनेश है। जब मैं स्कूल से लौट रहा था तो मैं बस में चढ़ के जा रहा था, तो उसमें गेट बंद हो गया था, तो मुझे पैर रखने का जगह नहीं मिला था। फिर मैं नीचे गिर पड़ा था, तभी बस मेरे ऊपर से चली गई थी। यहाँ पे आकर उधर सफदरजंग में गए थे ना, तो एक डॉक्टर जी ने यहाँ की सूचना दी कि यहाँ पे जाइए। फिर हम यहाँ पे आए थे। मैं 7th क्लास में पढ़ता हूँ। मैं चेस, लूडो, क्रिकेट, यही पहले जब लगाया था तब थोड़ा गिरता था। फिर अब ठीक हूँ। चलने के अलावा खेल सकता हूँ, इधर उधर जा सकता हूँ घूमने।
इसमें क्या फर्क है? मतलब जब तुम्हें पहली बार पैर लगा तो तुम्हें कैसा लगा?
मुझे लगा अब मैं चल सकता हूँ।
So Dinesh is wearing our V1, and we're in field trials right now for our V3, and we actually hope to enter the market globally in the middle of next year. So that's it. Thank you.
So I have the advantage or the disadvantage of going in the end. So I'll try and keep it as brief as possible. So when I started thinking about what I should present here, I went through a number of different iterations. I thought, okay, maybe I should cover the typical things like affordability or, regulatory issues in India or corruption or access. And I said, that's things you've probably heard about 10 times already. So what should I tell you that you've not heard about before? So I said, okay, maybe I should tell you my story. Then I said, no, this is Silicon Valley. You've probably heard this story more times than I've told it in my life. So I said, okay, let me take something that's central to Silicon Valley, innovation, and show you how that gets adapted or not adapted in different places. So I'm taking a slightly different approach. Just bear with me. You'll see where I'm going. So I'm going to show you a couple of pictures, a place where innovation is pretty significant. Any guesses where this is? That's right. So it is Galapagos. Extremely diverse. There's diversity everywhere, on land, in water, in sky. Since we've already gone to where this is, why? Why is this diversity so rich in this one small group of islands? I mean, if you look at it on the island, there are about 1,000 to 10,000 species. You go just 100 kilometers in the water, there are over 1 million species. So what is it that drives that innovation there? Right temperature. There are 3 ocean currents that sort of converge there. There is both warm and cold breeze. There is good mobility, and diversity is encouraged. Obviously, connections are made, failures are discarded quite quickly. And finally, that leads it to become nature's innovation platform. When I come here, I feel the same way. Silicon Valley has that same sort of vibe to it. It is man-made innovation platform. Now, why is this difficult to replicate in India? Very simply, we are a very hierarchical culture. Right in the beginning, it started as a class society. We have castes, we have religion you go everywhere, every Indian is different from another. How many Indians are there in the room right now? Okay, 5. Probably all from different parts of the country, all from different religions. We won't even relate with each other's cultures. So obviously, you guys wouldn't relate either. We are taught right from the beginning in school that this is the way to do things. There's a very standardized, structured way. Diversity is discouraged, almost looked down upon. So obviously, it doesn't encourage people to take risks, to share opinion, right? And worst, we have very poor listening skills. So how many of you guys have been in a room with Indians? All of you, right? We don't listen. We love to talk. So there's this ad that comes on TV in India where, they talk about how Indians love to give opinion. So you come with anything to them and they will give you their opinion. But if you want them to listen to yours, it's really hard to do. Now imagine running a company full of Indians who don't listen to each other. However, we try to do something slightly differently at Core Diagnostics. So that's our building there. Looks like we own the entire thing, but we don't. We are one small floor on the top. But the reason we did that was we wanted to be perceived as a big company. So we said, even though we're small, we want everyone to look at us and think, okay, this is the company to go and work in. So that was the idea behind it. You can see that from the highway right at a distance. So I've got employees who walk in and say, I saw your signage. Do you have the whole building? I'm like, after you sign that offer letter, I'll tell you. That's a picture of our entrance. This is, in fact, that's where we sit and work. That's me right at the bottom. So completely startup-like feel. Possibly you guys have seen this before, but in India, this is extremely unique. It's very hierarchical. Everyone has a room. Everyone has a cabin. The higher up you go, the less approachable you become. Versus in our company, that the guy you see sitting there in the corner is the junior most employee. And I'm sitting right there as well. So the whole company is sitting right there. So there's lots of engagement, and hierarchy is non-existent because of that. Another picture there. One more picture. These are actually people who are proper employees. One is on the lab side, the other is on the sales side. But when we were shifting in, picked up boxes, did the whole thing. And you wouldn't notice this in India because in India, manpower is cheap, which means you could find people to do this easily. But the kind of culture we fostered, people want to take ownership. People want to do everything with their hands. Some more pictures. Again, another very unique situation. That there is one of my co-founders. Me and him are probably the youngest people in the company, but the whole group is listening to us. And the reason is, from the beginning, it's been engineered that there's no hierarchy. Anybody who has a good idea will be listened to. That's my CEO there. Some of you might know him, Ajit Singh. I know one or two of you do. And that's my junior most employee. But you can see they're both as engaged, as involved in the process. Something you would usually see in Silicon Valley, but we have that back home as well. That's our first shipment of samples coming in. This is a very interesting story. So we are, at 2 days before our launch, realize our microscope isn't working. This boy here in the turban travels 10 hours to go and get a microscope. He's in sales, so not even related. Picked up his car, reached there overnight, brought the microscope back. So that's the sort of culture we are building and trying to foster. Again, to me, this picture shows pride, shows ownership. He's a simple phlebotomist, but this is the first sample when he was going to collect it. These are a couple of pictures of our team here. So what is different about us? Number one, like I showed you, very open spaces, no offices. Encourages lots of communication, encourages dialogue. Very unique interview process. So how do I do an interview? I don't do an interview. I tell my employee, you interview me. And immediately they're confused to begin with, but then they start asking questions. And based on the questions they're asking, we judge them. So immediately listening gets checked. Because when you are asking somebody a question, you see whether they're waiting to listen to your answer or not. And then you see whether they fit in with your style or not. Otherwise, as interviewers, we lead candidates a certain way, the way we want. This way, we leave it completely open. We've had some great hires thanks to that process. And finally, thanks to you guys, we have a lot of close interaction with Silicon Valley, with people like CardioDX that allow us to learn the best practices and take them back there. So that's it. But essentially, want to reiterate, I could have gone back and given you a strategy presentation. I could have told you what's different about us. But that's not what's different about us. What's different about us is the fact that we've taken your culture and tried to integrate it within our country. Quite challenging, but we are doing our best. Right. Thank you.
Again, I do not want to stand too long between you and the wine. So, but I'd like to open up to Q&A. And if we do run out of time, all of us are around, so please feel free to stop us during the reception or at dinner or anytime afterwards, or just reach out to us. So, questions?
I have a question.
Okay. Yeah.
So my question is for Rev. I'm very curious about reverse export with you guys for a number of reasons. One, because you're in the ecosystem here where there will be a lot of people looking at what you do and hopefully recognizing value that could be brought back here into other countries or other geographies. So could you comment on that?
Sure.
And I'm sure that you've got inbound requests, and I'd be curious to know if there's a theme to them.
We do get inbound requests. Yeah, really briefly, with both the knee, we see the V3 as really the product that should go to market. We've already been getting requests for it from the U.S. for about 6 months. The regulatory environment is such that you need ISO certification on the knee. With Brilliance, we've actually been getting requests from families, because as you can guess, if you have a phototherapy device that's like super affordable, why not just buy your own and take it home, right? But the FDA obviously oversees that. We don't have FDA regulatory approval. We design everything to regulatory approval, and Brilliance is expected to get CE mark in the next couple of weeks through our partner, Phoenix. The countries we're operating in right now don't have that regulatory requirement. And one of the things that's really interesting, and I don't want to short shift going into new markets. When we look at new markets, we look at the barriers to entry, and we don't say, for example, pick a place that just has high social need and capacity to pay. We look at what's the tariff structure. Can we take the money out of the country? Argentina, not a great start. We look at where are the areas in the region we can really launch in and then go from there. But we do get demand from the U.S., and as of right now, it's a bit of an unresolved question. I will add that we're pretty little, as I mentioned. We have IP, but we could still get squashed like a bug by some of you big guys out there. So, I would add that it's not our mission. I mentioned our mission is really focused on $4 a day and less. So, there's things that we could look at in terms of revenue models for a nonprofit, but right now that's where we are.
Okay. There was a question back there. Yeah.
So more a question for Wendy and your tiered Chinese strategy. In that middle tier, when you're looking at the less differentiated products or products out of patent, how do you deal with local competition, the knockoffs, if you will? I think there's been some industry examples where the Chinese companies will come in and just do that. They kind of own that tier. How do you kind of deal with that issue?
Actually, we compete with them. If we're not competing, the way that we feel about this is if we're not competing with them, we're actually leaving out a significant market. And there we use, we have a lot of expertise internally from our product development. So we partnership with local companies. We actually pick the best local companies to partnership with. And then we actually, from a cost perspective and access perspective, we will have the same competitive advantage as the local companies to deal with government distribution access as pricing. So that's how we deal with these off-patent products. And we bring the product quality a little bit better than the local products. So the image that we present and also the marketing expertise that we have in those areas bring huge value as well in differentiate our product versus some of the local competitors.
Other questions? Yeah, go ahead. Yeah. Can we get the mic over there?
So I actually wanted to just make a comment reflecting over the whole day. It's been a really interesting day and tremendous information. But I think one of the impressions one could go away with is, and perhaps I'm wrong, but sort of I have this impression, is that the overall message is we have to drive costs out of the healthcare system to succeed. And I would like to push back on that. I think as a medical device industry, we make a difference in people's lives. That's what we really do. And I think the DREV example is obviously tremendous, but we're all doing it. And we can do it at a profit. And in fact, if you think about knee replacement, before knee replacement, patients who could no longer stand the pain when they stood on their knees had a fusion. And that meant in one or two knees, they could no longer bend them. So knee replacement made an enormous difference to people's lives. And it added costs to the healthcare system. But it was cost that was worth it. It was cost that made a difference because people's health were improved. And some of our devices even save lives. So I would like to put a strong push in for being proud of what we do and owning that sometimes we add costs to the healthcare system, but it's worth it. So I'd just like to add sort of the discipline of how we demonstrate it. Obviously, we know this, which is we do the right clinical studies that compare current therapy to our therapy. We document the improved outcomes, and we quantify them through quality-adjusted life year analyses and other types of economic analyses. And the quality-adjusted life year is actually a tremendous, powerful instrument that we can use to actually prove to healthcare systems that we're adding value and at what cost. So in Europe, they'll even tell you, most systems in Europe are willing to pay for something that adds benefit that doesn't cost more than 35,000 euros more. So we now have a number that we can even shoot for. And our healthcare system hasn't yet quantified things in exactly that way, but we still have a lot of powerful tools at our disposal to really prove to people that we're adding tremendous value to people's lives. And I certainly am not in this industry to be able to say on my gravestone when I'm gone, I drove costs out of the healthcare system. What I hope I can say is I made a difference in people's lives. I really improved people's clinical outcomes. I made a difference to the people. And that's, I think we should be proud of that. But document it properly.
Any other questions or comments? Yeah.
Yeah, could some of you or each of you comment on how different cultural sort of expectations around how patients perceive value might lead to differences in how you put together your product development strategy or your business innovation strategy, just different areas of how you run your business based on different patient perceptions and requirements around value?
Yeah, sure. Zoya, would you like to start?
Yeah, so in India, actually, it's a very unique situation because patients pay for most of the healthcare. So it becomes very, very relevant. However, even there, there's a very interesting dynamic because patients want the best in healthcare no matter what the cost. I've met patients who've gone ahead and sold their homes in order to get cancer treatment. So having said that, the doctor doesn't buy into that. So it's really the doctor's mindset that you need to package your product for. The doctor will still ask you, how much is it worth? What's the alternative? And at the end of the day, the doctor is the decision maker, not the patient, even though the patient is paying. So cost is important, but like you just mentioned a little while back, it's value that's even more important, even in a country which is resource starved like ours. So from that perspective, a better product is worth the value, even if it's more expensive.
Krista?
I think there's so many cultural considerations. Hierarchy is a huge one. We see that nurses won't tell doctors what they think. Sometimes nurses aren't even taught to think because of the extreme hierarchies. Just in terms of context, environmental context, a lot of medical devices with electronics are designed to 35 degrees C. That's not the reality in most of the world around the equator. It's 40 or 42 degrees. I mentioned some of the things we see with users. And I actually do want to address the affordability thing. What is happening in the industry is amazing and what has happened, but the reality is we have to deal with affordability. When I'm in rural hospitals in Africa, I see Chinese devices, and they're not high quality. Cost is hugely important if you want to reach most of the people. Even in Brazil, we hear about 60% of the population can't get good access to phototherapy. I can tell you in India and West Africa, 90% of hospitals do not have access to blue light because of cost. So the industry is changing, and the cost really needs to be addressed if you want to reach emerging markets, particularly groups that have not had access to healthcare.
Yeah, from my perspective, we actually have the end user who is the patient, and also the the lab workers who are dealing with our products. So we actually have set up demo labs in China. Traditionally, we won't do here in the U.S. market because we need to do a lot of training with the different labs who are staffed with very different skill sets of people. So we do that, and in addition, we do a lot of training. So we go out to do a lot of seminars with patients. And in addition, the localized product actually have a preferred acceptance with the patients in China. So that aspect we have to look at, and the local innovation are really the physicians would prefer those prescriptions or even those type of devices. So we need to look at that aspect as well when it comes to the culture aspect and looking at those in the mid-cap mid-tier market.
And the technology that I'm currently working on is very new in terms of introduction to the markets, but a couple of the things that we continuously look at from a medical device perspective is there are many cultures out there who would prefer not to have an invasive device. So they're still looking at the drugs or the other options before they'll go to the medical device. But also, as mentioned, the cost component is a very critical and important thing for a company to look at. And you can't go to market with the same technology and price point that you go to market in the U.S. with in many of these emerging markets. And that's something that has to be addressed, I think, early enough in the pipeline so that you can actually create the technology for those various markets so that you can actually allow patient access to those at a cost that they and their system can afford.
So at this point, I'd like to thank the fellow panelists and all of you. I know, again, it's late in the day. It's been a really fantastic day, and so I really thank you for the attention. And again, please feel free to stop any of us with any questions that you might not have had the chance to ask. So thanks.